Hello everyone, hope you're all doing good. In this video, I want to discuss with you about the mechanism of labor. First, let us see what is labor. Labor is a process in which the fetus, especially after the period of viability, is going to expel from the uterus through the genital tract to the exterior world. Clear? So, fetus expelled from the uterine cavity through the genital tract to the exterior world, and all these things should happen after the period of viability. Now, what does WHO says about labor? See, WHO has given a definition for labor. I am going to share you the keywords alone that will help you in knowing what is a normal labor means. Okay. So, if you take a normal labor, it should have the following features. Number 1, it should be spontaneous in onset. Then, the labor should remain low risk from the starting of the labor throughout the labor as well as after delivery also. Then, the infant should be mostly in a vertex position. Any position other than vertex is considered a small position, and it should be spontaneously born. And a normal labor should happen between 37 to 42 weeks of gestational age, and the birth should happen through the vaginal route, and after birth also the mother and baby should be in a good condition. Clear? So, all these points should be tick marked to say that it is a normal labor. Clear? Once again I will come up. So, WHO definition for normal labor. First one, it should be spontaneous in onset, then there should be low risk from the starting of the labor, throughout the labor, and the delivery also should be low risk. Then the infant should be in vertex position and it should be spontaneously born. It should happen between 37 to 42 weeks of gestational age. Then it should happen through the vaginal route, and the mother and the baby should be in a good condition even after delivery. Clear? Right. Now, we have to know some important points. Okay, we have 3 P's of labor. Okay, so these 3 P's are very important. Okay, so these include number 1, the passage, number 2, the passenger, and number 3, the powers. Okay, now we will see what are these individually. First one is about the passage. So, passage means it includes the bony pelvis and soft tissues. So, bony pelvis can be assessed by clinical pelvimetry, and soft tissues include your lower uterine segment formation, then cervical dilatation, and then also the vagina, which is going to distend and stretch. Clear? Right. Now, we will see about the passenger, that is the fetus. Okay. So, how the features of a fetus should be to go through a normal labor. The lie of the fetus should be longitudinal. The position favorable and the most common position is left occiput to anterior. Presentation, as we have seen already in the WHO definition, it should be a vertex presentation, and attitude of the baby which is favorable is a universal flexion. Okay. The head of the fetus should be at a station 0 and below, and fetal weight should anywhere between 2 to 3.5 kilograms. Okay. Now, let's start with the mechanism of labor. I am going to discuss with you about the mechanism of left occiput to anterior position, which is the most common position. Okay. So now I am going to discuss about the mechanism of labor in detail, and I am going to discuss about left occiput to anterior position. Okay. So, mechanism of left occiput to anterior position. Here you have to know that this is the common longitudinal cephalic presentation. Attitude of the fetus is flexion. Presenting part is the posterior part of the vertex, posterior fontanel, and the denominator is going to be the occiput. Clear? Now, we will see what are the cardinal movements of labor. Cardinal movements of labor, see, this can be remembered by using a mnemonic. I generally remember as it was a firer. Okay. So, number 1 movement is going to be engagement. Number 2 is descent. Number 3, that is F, is going to be flexion. Number 4, IR is going to be internal rotation. Then again E is going to be extension, and R is going to be restitution. Okay. And after that add one more ER. So, this will become external rotation, and sometimes you can even add a 8th one, that is expulsion. Okay. So, it was a firer. Okay. So, this is how you can remember the cardinal movements of labor. Okay. So, the order is going to be the same. So, no changing in order, and remember to join this IR, then you will remember about what is the and what is this R. Okay. And this ER will go together. Here IR will go together and here ER will go together. Clear? Yes. Now, we will see about engagement. So, when we speak about engagement, in simple words, engagement means dipping. That is, the fetal head is going to pass through the inlet. Okay. So, it is dipping when the presenting part of the fetus has passed through the plane of inlet. In other words, if I explain even more precisely, I am going to say that the widest diameter of the fetal head is going to pass through the inlet. Okay. Suppose if it is a cephalic presentation, it is the biparietal diameter which is going to be the presenting diameter that is passed through the inlet. Suppose if it is a breech presentation, it is going to be the intertrochanteric diameter. Clear? Okay. And remember another fact that engagement in primigrávidas happen 2 to 3 weeks before term, whereas engagements in multigrávidas will occur usually after the onset of labor. So, engagement can be assessed by doing either abdominal or vaginal examination. Suppose while doing examination through the per-abdomen examination, repeating. So, assessment of the engagement can be done through a per-abdomen or a per-vaginal examination. While doing a per-abdomen examination, suppose if engagement has not occurred, then it is said to be have a floating head. Okay. In per-vaginal examination, the bony presenting part, in per-vaginal examination, the presenting part should be at the level of ischial spines or it should have crossed the ischial spines. Clear? So, presenting part should be at or nearly at the level of ischial spines. And remember, this presenting part should be the fetal skull bone. Okay. Sometimes if cases of caput, we will be seeing a soft swelling. So, caput presentation is not considered to be the engagement. Okay. Yes. Now, remember that the fetal head engages with its sagittal suture, that is the anteroposterior diameter of the fetal skull, in the transverse diameter of the maternal pelvis. Clear? Okay. Now, we will discuss about some of the important and confusing terms, synchytism and asynclitism. See, it is synchytism. Okay. Synchytism means the S for S you have to take. Okay. So, we are going to talk about the sagittal suture alone. So, the sagittal suture is going to be in the midway between the pubic symphysis and the sacral promontory. Okay. So, if I draw the pelvis like this, okay, if I am going to draw the pelvis like this, say this is the sacral promontory, okay, and here we are having the pubic symphysis, okay, and if I take the fetal head like this, I am going to check for the sagittal suture position. So, this should be in a midway like this. So, this should be in a midway like this. Okay. So, this is synchytism. But if for any reasons this position is not maintained, the sagittal suture is going to go towards the pubic symphysis or towards the sacral promontory, then it will be named accordingly, and that condition is collectively called as asynclitism. We will see the types now. Okay. In asynclitism, you have two types. Okay. You have the anterior asynclitism and the posterior asynclitism. Okay. So, anterior asynclitism is when the anterior parietal bone is going to present. Okay. So, here anterior parietal bone presents, whereas in posterior asynclitism, your posterior parietal bone presents. Okay. Now, we will see about the different types of asynclitism. So, asynclitism can be anterior asynclitism or posterior asynclitism. Okay. So, anterior asynclitism is where the anterior parietal bone is going to be at a lower position than the posterior parietal bone. Okay. Whereas in posterior asynclitism, the posterior parietal bone is going to be the presenting parietal bone or the parietal bone at lower position. Okay. And if you see in anterior asynclitism, the sagittal suture will be closer to the sacral promontory. Okay. Don't ever get confused here. Okay. So, sagittal suture is close to the sacral promontory, whereas in posterior asynclitism, sagittal suture is close to the pubic symphysis, and anterior asynclitism is also known as Needles obliquity. Okay. Whereas posterior asynclitism is also known as Litzman obliquity. Anterior asynclitism is more common in multiparous, whereas posterior asynclitism is more common in nulliparous. Okay. So, how I am going to remember is, see, anterior asynclitism, it is also known as Needles obliquity. It is more common in multiparous, and you remember this S. Okay. So, this S is going to take sacral promontory. It is ANMs. Okay. So, axillary nurse midwife. Okay. So, that abbreviation I have kept as ANMs. So, it is anterior obliquity, that is anterior asynclitism, Needles obliquity, common in multipara, and this is sacral promontory. Okay. If you want, you can add a P also. Okay. So, we will see the picture for better understanding now. So, this is a normal synclitism. Okay. But if you see the sagittal suture, okay, so this is the sagittal suture, like, so it is midway between the pubic symphysis as well as the sacral promontory. Okay. Whereas, if you see the anterior asynclitism, which is the Needles obliquity, this sagittal suture is going backwards. Okay, and it is going to towards the sacral promontory. Okay, so that one you have to keep it in mind, it is going backwards. Whereas, in the posterior asynclitism or the Litzman obliquity, what is going to happen? The sagittal suture is coming forwards. So, when this is happening, the parietal bone which is going to present is, for the anterior asynclitism, it is the anterior parietal bone which is going to present, and posterior asynclitism, it is the posterior parietal bone which is going to present. Clear? So, the parietal bone name goes synonymous with this type of asynclitism, and the sacral promontory, and the sagittal suture movement goes towards the opposite of the name of the asynclitism. Okay? Right. Why this is important? Synclitism or asynclitism, why it is important? See, when the baby is in synclitism, the presenting diameter is going to be biparietal diameter, which is around 9.5 centimeters, whereas in asynclitism, the presenting diameter is going to be suprasacral subparietal diameter, that is around 8.75 centimeters. Okay. So, when this is happening, sometimes asynclitism, since there is a reduction in the presenting diameter, this will be favoring a larger head to pass through the inlet. Yes? Right. Suppose if you are able to find a marked or persistent asynclitism, then that time asynclitism becomes abnormal. We will see the next cardinal movement about descent of the fetus. So, descent. See, descent is one of the cardinal movement in labor which is going to start right from the engagement, and it is going to happen along with the other cardinal movements also. Okay. So, whatever cardinal movement comes, okay, internal rotation with the descent, flexion with the descent, extension with the descent, external rotation with the descent, descent is going to happen continuously. Okay. So, it continues throughout the labor, and other movements are going to be superimposed. Regarding descent, sometimes the primary gravida descent may not occur even until the second stage. So, remember, in descent for primary gravida, it may not occur till her second stage, whereas for the multigravida, the descent will usually start with the engagement itself. Okay. So, what I told for engagement, primary the engagement occurs first, okay, and for the multi it will be occurring with the onset of uterine contractions, right, whereas for the descent it will be occurring early for the multigravida, whereas for the primary gravida it will not occur till the second stage. Clear? Yes. And we will see what are the factors that is going to cause this descent. Okay, factors or forces causing descent. Number 1, it is the direct pressure given by the uterine contractions. Number 2, the pressure given by amniotic fluid. Number 3, the bearing down efforts given by mother, and here the maternal abdominal muscles play an important role. And the fourth factor is the fetus. Okay. So, there is extension and straightening of the fetal body. Clear? So, all these factors put together will be helping in the descent of the fetus. Okay. And remember another point what I told you, descent is going to happen right from the engagement till the birth of the baby. Okay. It will be occurring with all the other cardinal movements also. Clear? Yes. Now, the next cardinal movement is flexion. Okay. See, flexion is the natural attitude of the baby. So, in utero itself, it is the baby is going to be in the universal flexion, right? But as the cardinal movements of labor are started, and when it is going to descend down and it is going to meet a resistance, the resistance can be from the cervix, the pelvic floor, or the pelvic side walls. What happens is, this is, see, imagine this is the cervix or pelvic floor or pelvic wall. The baby is going to descend like this. Already it is in a flexion. And when it is going to hit, it is going for a further flexion like this. Clear? So, what I said is, it exits before the onset of labor. This is the natural attitude of the fetus in utero, but as the descending head meets the resistance, the resistance can be from cervix or pelvic floor or pelvic side walls. Then it undergoes further flexion. Clear? And here you have to remember another point, that as the baby is getting flexed, okay, consider this is the anterior part and this is the posterior part of the fetal head, okay. So, as it is going to get flexed, okay, we will be getting, okay, the occiput down, okay, the occiput is going to come down, whereas the anterior part of the head, okay, it is going to go inside like this, okay. So, finally occiput will be the leading thing, and when you do a perivaginal examination, you will be able to palpate the posterior fontanel, okay. So, the occiput will be ahead of the inciput and the posterior fontanel will be ahead of the anterior fontanel, clear, and it will be like the baby's chin will be going and touching its chest, clear, okay. So, what happens is, occiput descends in advance of the inciput, then posterior fontanel is lower than the bregma, and the posterior fontanel is lower than the bregma. Also, when this is happening, the baby's chin is going to touch his or her chest. So, remember another important point, that while this flexion is going on, the presenting diameter is also going to change, okay. Suppose if you say that it is in the occipitofrontal diameter, which is around 11 centimeter, while this extra flexion is happening, this will change to suboccipitobregmatic diameter, which is 9.5 centimeter, okay. See, it may seem like only there is a reduction of 1.5 centimeter, but even this reduction of 1.5 centimeter during a natural labor for the fetal head to pass through the pelvis is very, very important. Clear? So, this is the importance of flexion. Now, we will pass on to the next one, internal rotation. So, in internal rotation, I want you to understand two factors. Number one, if you take the maternal pelvis, the inlet is going to be transversely oval, whereas the outlet is going to be anteroposteriorly oval, right? And if you take the fetal head, how it is going to engage in the maternal pelvis? In the inlet, this is going to engage in the oblique diameter or anterior diameter, anteroposterior diameter, yes, mostly, and in the outlet, it will be coming to the anteroposterior diameter, okay. So, this is going to just match with the pelvic diameters, clear? So, what is going to happen is, the occiput is going to rotate now, okay. So, the occiput is going to rotate, how many degrees means exactly 45 degrees to the right, okay. That is, it is going to rotate from the occipito anterior position towards the right 45 degrees. So, what will happen? If it is in the left occipito transverse position, it is going to come to the left occipito anterior position, okay. See, I will give you an example. So, if you take, this is the circle, right, we will take here is the pubic symphysis and here is the sacral promontory. Okay, and I'll be dividing the quadrants also. So this is occipito-anterior, this is occipito-posterior. Let's keep this as the left side and this is the right side. So you have left occipito-anterior, left occipito-transverse and left occipito-posterior. Yes, here also you have right occipito-anterior, right occipito-transverse and right occipito-posterior. Okay, so 45-degree rotation means what is going to happen is, if it is in the left occipito-transverse position, it is going to come to the left occipito-anterior position. Yes, and also suppose if it is in the left occipito-anterior position, it is going to come exactly to the occipito-anterior position and so on. Clear? So I hope you have understood this. And sometimes what is going to happen is, rarely in some cases posterior rotation may happen and it can present as occipito-posterior position also. Clear? Whatever occipito-posterior, right occipito-posterior, left occipito-posterior, so it can present to occipito-posterior position also. Clear? Yes. So what is going to happen is, in 2/3 of the cases, most of the time internal rotation will be completed before it reaches the pelvic floor. Okay, before it reaches the pelvic floor. Whereas in 1/4 cases, it will happen only after the fetal head reached the pelvic floor. Clear? Yes. Now you have to understand the fact that we have seen about the fetal head only. So the fetal head is going to transform to the occipito-anterior position, right? But what about the shoulders? The shoulders are still in the occipito-anterior position, left occipito-anterior position, right? So there is a difference between the fetal head and the fetal shoulders here. 45 degrees is not changed by the shoulders. Okay, so what happens is, there is a neck flexion here. Okay, the neck is in a change of flexion. Okay, the neck is twisted around 45 degrees now. Clear? So this you have to understand this factor also. Okay, so there is a neck twisting around 45 degrees. And most of this internal rotation will be happening during the second stage of labor. Clear? Right. So if you take the head is in the anteroposterior diameter, then the shoulders are left behind in the left oblique diameter. So there is a twist in the neck around 45 degrees, and most of these events are going to happen during the second stage of labor. Clear? Okay. We'll see the next cardinal movement, that is extension. See, when the fetus is going to come and reach the pelvic floor, two factors are going to come into play. Okay, so what are the two factors? First factor is the uterus, which is going to give downward pressure. And number two is pelvic floor, which is going to give resistance. Clear? And also understand the fact that the anterior wall is going to be formed by the pubis, which is 4 to 5 centimeters, okay, roughly. And which part of the fetal head is going to be in contact with the anterior wall? Yes, it is the occiput, okay. So this is the occiput is contact here, right? And same way, the posterior wall of the pelvis is formed by the sacrum, and this is going to be around 10 to 15 centimeters, and here synciput of the fetal head is going to be in contact with the posterior wall. Clear? Right. The point you have to understand here is, the synciput is going to travel a longer distance than the occiput. Okay. And also, there is bulging of the perineum. Okay. Bulging of the perineum, that is followed by crowning. Okay. That will happen with the further descent. Okay. So with crowning, what is going to happen is, occiput hitches under the pubic symphysis and it doesn't recede. Okay. So that is exactly what is crowning. Clear? So after crowning, what happens is, first the occiput is going to pass down. Okay. Then there is a rapid extension of the body that is going to cause the fetal phase to born in an order. Okay. So you can imagine your face itself. Okay. It starts right from the bregma, then forehead will be born, then nose will be born, then your mouth, and then finally your chin. Clear? And immediately after delivery, what happens is the fetal phase will be lying as such, it is going to touch the maternal anus. Clear? So, first one is occiput passes the outlet slowly. There is rapid extension of the body of the fetus. So, that will cause the synciput to sweep across the sacrum. Okay, synciput sweeps. So, that causes the synciput to sweep across the sacrum, and the baby is born in the order. First comes the bregma, next comes your forehead, next comes your nose, mouth and chin. And after everything is out, the chin will be lying such that it will be touching the maternal anus. Clear? Right. And the next cardinal movement is external rotation. In external rotation, I have to explain about 3 factors. I have to tell about restitution first. Okay. So, if you ask me what is restitution, already I said to you there is a neck twisting which is existing. So, that twisting hasn't recovered till the delivery of the fetal head. Okay. So, after the head delivery, what happens is the shoulder is not going to make any change. Understand that point. Okay. The head is going back to the original position. Okay. So, I told you the head is in the occipito-anterior position now, right. So, the head is in the occipito-anterior position now. Again, it will go back to its original position, which is left of occipito-anterior position. So, as it is doing, as this twisting is undone, what happens? The head and the shoulders are going to be in the same alignment. Clear? Right. So, that is what is about restitution. You have to know about shoulder position now. So, the diameter of shoulder which is going to present is bis acromial diameter. Okay. And remember, this bis acromial diameter is going to present in the anteroposterior diameter of the pelvis. Accepted? So, the anterior shoulder is under pubic symphysis and the posterior shoulder is under the sacral promontory. Okay. Now, the first shoulder that is going to be born is the posterior shoulder by a lateral flexion mechanism. Okay. So, there is lateral flexion. Imagine this is the anterior shoulder, this is the posterior shoulder. Okay. So, there is a lateral flexion mechanism which is going to deliver this posterior shoulder followed, and as the posterior shoulder is delivered, the anterior shoulder follows. Clear? And then we have to see about expulsion. Expulsion means once the head is delivered and shoulders are delivered, the rest of the baby is going to come out easily. Clear? And it needs only uterine contractions. So far we have travelled with the baby only in imagination. Now we are going to see this picture for better understanding, right? So this is the picture. See, first there is engagement, descent and flexion. They have shown it in a single diagram. Okay, so there is engagement, descent, and the baby is in a universal flexion position, right? And the next one is what is going to happen is this is in the left occipito anterior position. Okay, see, when you are seeing such kind of diagrams, what you have to know is your right is patient's left and your left is patient's right, because you will be seeing the patient. You have to imagine as if you are seeing the patient, then it will be easy. Okay, so this is going to be the patient's left side and this is going to be the patient's right side. Clear? and then you have to check where is the sacrum and where is the pubic symphysis. Okay. So, here the sacrum is here. Okay. So, this is the sacrum and this is the pubic symphysis. Okay. So, this is the right side. Okay. In this picture they have shown the, and in the fetal head you have to find the occiput. Okay. So, to find the occiput, what you have to do is you have to check for the anterior fontanel. Okay. So, this is the anterior fontanel, right. So, here is the posterior fontanel. So, that means this is going to be the occiput. Clear? So, this is a left, okay, occiputo, and it is anterior because the occiput is towards the pubic symphysis. So, it is a left occiputo anterior position. That's it. Clear? Okay. Now, the baby is in the left occiputo transverse position. Then what is going to happen is there is a state of internal rotation. Okay, and when this internal rotation is happening, see the occiput is turning towards the front now. Okay, the occiput has turned towards the front. Then there is external rotation, that is restitution has happened, that is untwisting has happened. Then there is extension where the rotation is complete. Then the shoulder rotation is going to happen. Okay, the shoulder rotation has happened and then the extension is complete and finally the expulsion has occurred. Clear? Okay. So, in this picture if you see, in this figure they have shown engagement, descent and flexion together. Okay. Here they shown the position of the fetal head. You have to understand while doing this kind of picture, you have to understand that the patient's left is towards your right and the patient's right is towards your left. Clear? So, this is my right. So, obviously the patient will be having a left side here and this is my left and the patient's right side will be here. Clear? Okay, you have to imagine as if you are seeing the patient. And then you have to see the pelvis and you have to find where is the pubic symphysis and where is the sacral promontory. I suppose to think that when there is a small joining like this, it is going to be the, yes, pubic symphysis and this is going to be the sacrum. Clear? And also you have to check for the fetal head and where the occiput is present. Always remember, when they have shown something in a diamond shaped, what is it? It is the anterior fontanel. So, this is going to be the synciput of the baby. So, this is obviously going to be the occiput of the baby. And now, join everything together. So, it is the left occipito transverse position. So, this is exactly like this, right? So, it is the left occipito transverse position. So, after engagement, descent, flexion, it is going to be at firer. So, IR is going to join now and it is, yes, internal rotation. So, in internal rotation what has happened is from the transverse position, this has changed into occipito anterior position, right. Then comes your extension where the rotation is complete, okay, it has completely turned down. So, by the time internal rotation has completed, okay, by the time of extension, then extension is totally complete here. See, the baby's head is coming out now and then what happens is there is external rotation, there is a restitution is happening, the twisting of the shoulders is not undone. So, that is being completed here, right, and then the shoulders are going to rotate, okay, and finally what is going to happen is the rest of the fetus is going to be born without any trouble, that is called as expulsion. Clear? Right. Now, after the expulsion of the baby, what else is left inside the uterus? Placenta is left, right? So, we will see the birth of the placenta also. So, birth of the placenta. Now, after the expulsion of the fetus, what is going to happen is the uterine contractions are going to start again after a few minutes. Okay. With this uterine contraction, whenever uterine contraction is happening, what we know that the upper segment is going to contract, right? And only in the upper segment the placenta is attached. So, it is going to retract. Retract means the cells of the uterus are going to become smaller this time. Okay. So, with this retraction what is going to happen is the placental bed is also going to become smaller. Okay. So, the placental bed area is going to become smaller and the placental bed area is going to become smaller means the placenta is going to be separated from the decidua along the spongy layer. Okay. Then the separation will be happening. Can you understand? So now first point, within few minutes the uterine contractions begin again. Then we know upper uterine segment undergoes retraction. So, that decreases placental area of attachment. So, this leads to detachment of placenta along the spongy layer of decidua. So, placenta will be separated from the wall of the uterus then. Okay. So, then it will be expelled down into the vagina, and that will be bearing down effort of the patient also helping this. Clear? And there are two methods of placental separation. We have Duncan's method. Okay. What happens in Duncan's method? See, the lower edge of placenta comes first. Lower edge of placenta comes first. Okay. So, as the lower edge of placenta is coming, both the anterior surface of the placenta and the posterior surface of the placenta, that is both the maternal surface of the placenta and fetal surface of the placenta are going to come together, right? So, maternal surface, maternal and fetal surface present together. And then we have the Sulci method. Here what happens is, remember the C, okay. C means the placenta is going to separate from the center, okay. C, this peak, okay. So, the placenta is going to separate from the center, okay. So, that means this is the maternal surface and this is the fetal surface. So, in the Sulci method, the fetal surface is going to present first, clear. So, this is the Duncan's method of placental separation, where the anteroposterior surface, that is maternal and fetal surface, are going to present together and it is going to happen from one edge. Whereas in Duncan's method, remember C, so from the center it is going to separate. So, from the center it is separating means the fetal surface is going to present, okay. So, but we do not have any significance with these methods, but you have to know just that there are two methods of placental separation. Clear? So, with this we are completing this topic on mechanism of labor. We have discussed about all the cardinal movements of labor, the importance, and also the birth of the placenta. So, until we meet in the next video, take care, happy learning, and bye bye.